Oh, it's an honor to be here with you today. Thanks for the kind invitation. I had the interesting task to do this literature review about bone trauma. I have a lot to talk. I will try in these 15 minutes to summarize the most important findings. I hope you don't fall asleep. It's not a new subject, this question of bone trauma. Erickson, Albert Brainmark talked about the importance of a delicate surgical technique, but in the last couple of years, more attention was paid to a new implant design, new surfaces, and less attention to the surgical techniques. So I think it's very important to revisit this subject. Why it's important, sorry, let me, why it's important to reduce bone trauma as much as possible. Because we need to preserve as much as possible the regeneration potential of bone and decrease bone resorption. Bone trauma in extreme cases can cause implant failure, but in other cases, although it doesn't cause an implant failure, we know that it can cause a delay in bone healing because we need the necrotic bone to be resorbed first before new bone formation occurs, okay? And this concept of minimizing bone trauma is very important when you want to place an immediate implant or do early loading. If you scan this QR code, you can get access to all the articles. In the case, if you can't, you can always send me an email and I will send them to you. There are some important clinical questions. I'll leave some of them here. What is the best drilling protocol regarding the drill material, the type of irrigation, the speed, the pressure, what's the impact of using a surgical guide, and what about the simplified drilling protocols? What's the minimal and maximal torque of insertion? But the real question is, do we have an answer for all of those questions? Implant bed preparation not only causes mechanical damage to the bone, but also an increase in the temperature of the bone adjacent to the implant. And this damage is time and temperature dependent. And heat trauma is an important factor influencing osseointegration and implant survival. The most cited article in the literature is the one from Erickson with a thermal chamber for intravital microscopy in rabbit's tibia that reached the conclusion that bone necrosis occurs when we exceed a temperature of 47 degrees for more than 1 minute. But this is controversial. Other studies point out different values. But the important is that in vitro studies, we can find very high temperatures that can cause bone damage. Heat generation is multifactorial. It depends on a lot of factors. And most of the studies concentrate only on 1, 2, 3 of those factors. But there is a very complex interplay between all of them. And the question remains whether the suggested drill protocol today is evidence-based or only based on expert recommendations. But as you can see, overeating depends on bone density, cortical thickness, the depth, if you are placing an implant on a healed side or healing side, if you are performing flap or flapless surgery, the pressure, the speed, the time, the type of drill wear, the type of irrigation, internal, external, the temperature, the use of surgical guides. So it's very complex. It's early in the morning and there are a lot of studies. I try to summarize them on these tables. I'm going only to highlight just a few points. And in the first look, you can see one thing. Most of the studies are in vitro and animal studies, okay? In some of the studies, drilling doesn't reach the critical temperature of 47 degrees. But we have some studies that evaluate the effect of speed, pressure, and time on temperature increase. We know that the variation of temperature with speed, it's non-linear. In some studies, when we increase the speed, temperature increases, but after a certain speed, we have a drop and then a stabilization of the temperature. Regarding the time, there is no doubt that an increased drilling time increases the temperature. So you can see that studies evaluate different aspects of this problem. Methodologies are very different, and it's very difficult to compare the results. Regarding the drill material, design, diameter, and wear, the material, we have some studies in which zirconia drills cause a smaller temperature increase. Regarding wear, there is no doubt that dull burrs cause an increase in temperature, so it's important to use sharp burrs. But if you read with attention some of the studies, you can see that some of them have serious methodology failures. For example, in this one, the maximum temperature measured by the authors was 27 degrees. We cannot not apply this on the clinical practice. We don't work on a cadaver, so we must account for body temperature, okay? Regarding the irrigation protocol, there is also no consensus. Some studies find that internal irrigation has better results, others that combined irrigation has better results, others say that the greatest temperature increase is on the surface of bones, so external irrigations works perfectly and we don't need more expensive systems. With internal irrigation, we always have the problem of clogging of the bone chips inside the channel. But in the majority of the studies, when we use irrigation, we can maintain the temperature below the critical threshold. And irrigation seems to be one of the most important factors in temperature control, okay? I tried because I don't know if you can read the tables, it's not easy, so I use this color code where red is no association, green there is an association. Regarding low-speed drilling without irrigation, we have several studies that say that drilling at very low speed without irrigation doesn't cause a critical increase in temperature. Regarding surgical guides, as you can see by the colors, we have some in favor, some against. Orange is, like we say in Portuguese, it's not meat, it's not fish, it's in between. Regarding the use of surgical guides, we must understand that first, the contact from the burr with the sleeve can cause an increase in temperature, and also the design of the surgical guide can impair the access of the irrigation fluid to the osteotomy. So we need to be cautious and use cooled saline solution, because there are several studies that demonstrate that when you use a saline solution at 5 or 6 degrees, it has a great effect on temperature reduction than using saline at room temperature. Regarding the conventional drilling versus a simplified drilling protocol, what is simplified drilling? It's those techniques that use just 1 or 2 burrs. There are several studies that analyze clinical and also the biological effect. Most of them say that there is no problem with simplified drilling technique, okay? No increase in cell death, clinical outcomes are okay, but I don't recommend, because with simplified drilling technique, you don't have a chance to correct the path of your osteotomy if you commit an error. So for inexperienced surgeons, it's more advisable to do the conventional sequential drilling. We have several limitations in the studies. As I said, most of them are in vitro with different experimental models. Some of them use artificial bone from dead animals that can be fresh or dry bone, and there is a difference in the water content. And also in artificial bone and bone from dead animals, we don't have soft tissues, we don't have blood flow, and that can have a lot of influence on the results. There are also different approaches to measure temperature increase. Most of the studies use thermocouples. It's a sensor that is placed within the bone. You can see on the top that small sensor that we make a perforation, we place the thermocouple inside the bone to measure the temperature. Some studies place only 1, others place 2, 3, 4, but thermocouples only give you spot measurement of the temperature. And they are placed at different distances, vertical and horizontally. Was muted. Yeah. And that can cause differences in temperature measurements. Also, we have a problem. We have a lot of implant systems with different drills, and it's almost an impossible task to compare them all. But most of the studies have a high risk of bias. For example, in a study to compare internal and external irrigation with these 2 burrs, we must also keep in mind that these burrs have different design, are made from different materials with different surface coatings, so this can have an influence on the results. Also, the process of sterilization and the impact on the wear. Some of the studies don't sterilize the burrs, and most of the studies use a constant pressure caused by gravity. We know that in clinical practice, we perform the osteotomy with intermittent load. And also it's different, the free running speed or the speed under load, under pressure. One thing is the independent drilling, and the other thing is the sequential drilling, because we know that in sequential drilling, it takes time for bone to return the baseline temperature, okay? So we can have different values if you only make 1 measurement or make several measurements in sequence, okay? Because bone can take 30 to 60 seconds to return to initial temperature. We know that placing undersized implants in, we know that placing implants in the undersized osteotomy can generate stress and strains. We know that bone has an elastic behavior, but if we go beyond a certain threshold, we can have a plastic deformation of the bone with micro cracks, ischemia, bone necrosis, and resorption. Let me show you these beautiful images from this study. Tomorrow I will talk a little bit more about this. But on the first image, you can see that this implant placed with high insertion torque caused micro fractures. You can see on the arrow. On the second image, you can see that pressure caused a plastic deformation of bone and bone delamination. And on the third image, at 6 weeks, you can see that the huge bone remodeling caused an increase in the porosity of cortical bone well beyond the site of the implant placement. So, to be very quick regarding this question of insertion torque against the color of codes, the green means that there is an association between high torque and bone damage. Red, there is no association between high torque and bone damage. You can see that most recent studies find an association between high insertion torque and bone damage. Some older studies don't find this association. Okay. We have some studies that evaluate the effect of high insertion torque on marginal bone loss over time. Also some animal studies that evaluate the biological effects of high torque. So I try to summarize the conclusions regarding the different parameters. There is no doubt that drilling in denser bone causes an increase in temperature. With a diameter, with the large diameter burrs, we have a larger area and an increase in the temperature. However, in sequential drilling, higher temperature increase is noted for the first drill because it has to win more resistance, it has to cut more bone in a vertical and horizontal aspect, and the last drills only remove a small amount of bone. Regarding time, there is also no doubt. Increased time, it's equal to an increased temperature. Regarding load and depth, we have conflicting results. Regarding bone sharpness, also no doubts. Dull burrs cause an increase in the temperature, but some studies demonstrate that we can use burrs about 30 to 50 times without a significant increase in temperature. Material, design, we have conflicting results, and it is in orange because it seems not to play a very important paper on temperature increase. Regarding the drilling protocols, there are no difference, but it is in orange because, as I said before, I don't recommend it. Regarding irrigation, we know that external irrigation with a cooled saline solution works well, but some studies find better results with internal. So, we must recognize that although we have some studies, we have a low level of evidence. We are here on the base of the evidence pyramid. We don't have a consensus for the threshold for the temperature for bone necrosis, and we don't have a consensus of what is a low torque or high insertion torque. And we must understand what is the difference between statistically and clinical significant. A difference of 0.5 or 1 degree might be statistically significant, But what is that in clinical practice? Is it significant? And for example, regarding marginal bone loss, when we work with average, that's always a problem, because in some studies we find a mean bone loss of 0.5, okay? But it's the average. And when we read all the article and find that some implants had 3 millimeters of bone loss, that is critical. Okay? So we need to find out the optimal drilling protocol, but I can say that we should avoid undersize drilling in dense bone. Okay? So that's it. A lot of more was left to say, but thank you for your attention. Any questions?
Thank you, Dr.
Welcome.
Alves. Please welcome. Join me in welcoming.
Thank you. It works?
Yep.
Thank you, Dr. Alves. You made a great job, great work, and it's great honor to be included in this interaction. And our main goal is to interact about our everyday practice, to have 100 success% in our surgical procedures. And your presentation was about the, can I summarize, trauma-less surgery, no bone heating, no bone trauma, and no bone resorption to achieve the high results during our placement. I have some questions. What are the considerations regarding torque value in implant placement? For example, what is the recommended minimum and maximum insertion torque?
Dr. Galactian, thank you for your question. Well, let me say that first, insertion torque only measures rotational stability, okay? And a high torque doesn't mean that we will have a successful osseointegration, and a low torque doesn't mean also that we won't have osseointegration. Some studies find that insertion torque is not correlated with ISQ. Yeah. Others find that there is an association. But also we can have a discrepancy between insertion torque and bone implant contact. Imagine the situation where you place an implant in the sinus. You have a high insertion torque because you have a cortical, but the rest of the implant is inside the sinus, yeah, and doesn't have bone implant contact, yeah, okay? We must understand that insertion torque depends on implant design, and implants with cutting threads can have a smaller insertion torque but still have a very good stability, okay? So it's not only the question of the bone quality, but also implant design is very important. We have seen on those images of the histological study the effects of overcompression, okay? So we must try to maximize the stability without compressing the bone. So I think we should avoid torques over 45 Newton centimeters. I think that for immediate and early loading, a torque between 30 to 45 could be the ideal situation.
And one more question, thank you.
I think more than everybody wants to get over 40 newtons. For what? So after you get 40 newtons, then you're going to do loading?
And
but you know,
not
if you
always.
get more than 40 newtons, we have more chance to fail,
Yeah.
as we know, right?
And
So
I
that's
forgot
a
to say one thing. In a high torque situations, we can also damage the implant connection.
Yeah.
Yeah. So if we want to wait 3 months, we need only 15 newtons to 40 newtons.
Yeah, it's enough.
And then if we want to do loading, and we want to get 40 newtons, right?
Yeah.
So that's the question. But we are talking about 100% success. not 90% success. Even if we get over 40 newtons, not failed. But sometimes it can fail. Why? We don't know. So we called it unknown failure because nobody knows. We get 40 newtons, but it failed after 3 months. Why? So we have to answer for that.
And
Right?
yeah, you are right. Thank you. But and what are the optimal surgical techniques? What we can use during our drilling protocols and placements, and for minimizing this bone trauma and to achieve the high initial stability, non-changeable stability without stability dip, that it was mentioned in Dr. Platt's presentation.
Okay, thank you for the question. Sorry. I think one trend in nowadays, it's personalized medicine. So we should adapt the surgical protocol to the patient, the bone conditions, and the first thing is to evaluate on the X-ray the bone quality. Next, in the surgery, when you place the first drill, you must try to understand the bone quality, and then you decide what to do. It's very important to adapt the drilling protocol to the clinical situation and the intended loading protocol. Okay? It's very important to perform an traumatic surgery. I suggest incremental drilling with a pumping motion to allow the escape of the bone chips. With the use of external irrigation with a cooled saline solution, use sharp drills, and avoid undersized drilling in dense bone. But I think
That's a problem.
other
right?
colleagues are going to talk a little bit more about that
Yeah.
and the
So-
surgical protocol.
But how do we know the bone density when drilling? It's a hard part, right?
Yeah.
It's subjective.
With the initial drilling, but it's still hard to determine the bone density in each steps. But we have to determine the bone density when we drill, and then we decide the drilling protocol, right?
Yeah.
So if we do on the side the drilling to the hard bone, that's a disaster, right? But the soft one is no problem at all for the risk of the overheating or overcompression. But the hard one is a problem. But we need a good fixation. But if we get the hard one or the D1, D2, it's good for stability, but it's not good for the bone trauma.
Yes, we have a
So
lot
we-
of failures
Right.
on D1 bone because it has less vascularization, less healing capacity,
Right.
and more subject for heating trauma, compression trauma.
So tactile feedback is very crucial in our practice, and we need to feel what kind of bone we have to deal with, and then we can modify how we can place our implants. So therefore, I think respecting the recommendations from the manufacturers is always crucial, and we will achieve in our practice this 100% success, as you mentioned, Doctor.
So we have to focus on how we get the ideal fixation, even in the soft bone and hard bone.
Yeah.
But soft bone, we
Exactly.
can do on-the-side drilling. But in hard bone, we have to get the passive fit, passive placement, passive contact, right? To
Yeah.
get rid of the bone trauma. Because we are talking about how do we get stability dip minimized, right? So most of them, we have success over 95%, even though we don't think about anything on the bone density, but we have a good success. But we're talking about, less than 5% success because we want to get to 100% success, even though we do the loading, early loading or immediate loading, right? So we have to think about that. We have to consider the bone density and the drill when you do the drilling, right? So it's a very important thing we have to think about. So do you believe that we can have a bone ischemic necrosis, right? Or overcompression by overcompression? I think it's always combined to the hard bone, like overheating,
Yes.
overheating and overcompression. Both they combine together, it will lead to bone necrosis, right?
Osteoclastogenesis, no? The
Right,
phenomenon.
right. That's true, right?
Thank you.
Thank you.
It's great.
Thank you.
Thank you so much for the,
Thank you.
yeah.
Thank you.